So the first item in the agenda is to take note of the membership and terms of reference. Membership has slightly changed. I think Councillor Simpson, Elizabeth Simpson, has left. Instead, we have Mark Purvis. Other than that, there's not much of a change. Then item number 2, apologies for absence. I think, Peter, you have something to say. Sorry, no. Any apologies for absence? Sorry, I missed it. Yeah.
Apologies from Alistair Blair, Rob Murphin, Vicky McFarlane-Reid, and Councillors Purvis and Sanderson, and Abby Conway.
Mark Purvis also sent me an apology. Okay, thank you. And item number 3, the minutes of previous meeting that happened in March. We canceled the April one. Are there any comments on the minutes? If not, I think our Vice Chair has been very careful and find out 2 minor corrections which have been passed on to Leslie, and they are in section 66. Item number 66, in the last paragraph, the following comments were made. The number of people, the first bullet, the number of people in Northumberland waiting for domiciliary care had reduced from 270 to 35. The waiting list has reduced to 35. Big reduction. And the second minor correction is in page 5, item number 67, the last paragraph starting with the following comments were made. It's the second bullet. There was some discussion about study into air quality, and the minutes should say there had not been any in-depth look into air quality. So these are the 2 minor corrections. Other than that, are you okay to pass that minutes in front of you as a true record of what happened in March? Thank you. Thank you. Now, disclosures of interest. I think that's where you come in, Peter. Sorry.
Thank you, Paul. It was just a standing declaration. In my day job, I am Chief Executive of Abbeyfield Northumbria, a provider of care and accommodation for older people. So that's a standing declaration. I'll make it particularly in connection with this item, the next steps for adult social care in Northumberland.
Thank you very much. Are there any other declarations? None. So we then move on to the first major item, item number 5, adult services conversation, position statement to be presented by our Neil Bradley, Director. But before that, Councillor Patterson will be making an introductory statement. Councillor.
Thank you, Chair. Good morning, everyone, on what is a lovely morning for once. Before I hand over to our very able Director of Adult Social Care, Neil Bradley, I just thought I would say a few words just about adult social care in Northumberland. Adult social care is open to over 7,000 residents, and we employ 1,000 dedicated staff to look after them. At some point in our lives, we will all need adult social care, so it is incredibly important to everyone. I just also wanted to touch very briefly on Communities Together. This was started during COVID with the help of the voluntary sector and our partners, and this was to help residents who were struggling during COVID. Our public health team have developed jointly now with adult social care, the voluntary sector and partners, to build on the work done during this time. And by all of us working together, we will be able to put residents, and well, it's such a wonderful thing really to be able to help our residents. You get such satisfaction out of it. And by doing communities first, we feel we can support people better and give them the right people to get in touch with before things go wrong. I think I'm right in saying that, aren't I, Jill? Over to you, Neil.
Thank you, Wendy, and thank you for giving me some airtime with this document this morning. I really appreciate it. I am conscious some colleagues in the room have seen this already. It has been presented to one or two other forums, but I know quite a number of colleagues haven't seen it. So I am going to whistle-stop through a presentation and an overview and give a flavour of the document and what we're trying to achieve here. The position statement, as we've called it, is something I've wanted to produce for quite some time, certainly ever since I came into the DAS role, which is just over a year ago now. But we've done quite a lot of thinking about how we wanted to present this information, and we deliberately haven't used the word strategy in this document. We haven't used it in the cover, we haven't used it in the name, and we haven't used it in the flavour of the document. Strategy often means quite a fixed plan and quite a fixed direction of travel. And what we were really keen with, but our want and desire to push towards co-production and involving people with lived experience, partners, the voluntary sector, etc., in the direction of travel for adult social care. We wanted to structure this document as our view of where we think we're at the minute and our view of where we want to go. And if you've had a chance to read it yet, and I would encourage you to read it, it's layered with questions throughout it of have we got this right? Is this the right direction that we need to go in? Are we doing the right things here? There's a flavour of those sort of questions throughout it. So it's not a fixed plan. Certainly the first year of this being in existence, I see it as being a lot of conversations with a lot of different groups and us refining it. And I could well see us changing this by the time we get to the end of the first 12 months if we think we're off course in any of the things in there. The COVID aftermath still sets the agenda for us predominantly in adult care. I know it does from many NHS colleagues. The NHS is under strain. I mean, Northumbria this week I know is having a hell of a time, and we're trying to assist with that, and that is something that we're revisiting several times a month in terms of the pressures that have been shown there and on other parts of the NHS. Workforce shortages are unprecedented post-COVID. There's been a fundamental change in the way that the workforce systems is being managed and the number of people that are opting out of work now. And public finances are very stretched off the back of COVID as well. And we've got to be cognizant of all of that in terms of what we're trying to achieve here. But the document is an attempt to move beyond crisis management, and that is what I've certainly been doing for the last 4 or 5 years in adult social care. We have just bumped from one crisis to another. And we've patched that up. We've become really good at patching that up, but we need to take a step back and start to achieve something that's more planned now and more our direction of travel. I've lost the signal. Do we have an IT recovery on that? Ah, brilliant. Okay. So I mean that's a little bit of the context. As I say, this is about a conversation, and it's about a conversation with all the groups listed on there. It's about a conversation with everybody that wants to talk about adult social care. To be brutally honest, nobody is excluded from this. And I would welcome suggestions from partners and from others around how we can make the conversations meaningful. There's a difference between talking to people and actually having something engaging that we then use. There's a lot of talking goes on from the public sector. But we don't always come up with solid outcomes from that. And I am really, really keen that this is real in terms of what we're doing here. The position statement itself is structured into 4 main areas. There's a bit of an overview at the start of how we think we're doing. There's a bit of self-assessment, and there's a bit about what the Care Act requires us to do as well, just to remind people of the legislative context that we work within. And then the 3 chapters that follow, that have the meat of what we want to talk about, are split into the way the Care Act is split. So there's a section about reducing the need for care and support, the prevention agenda, and stopping people hitting the system in the first place, or moving them away from the system as they're coming towards it. For those that cross the threshold, there's a bit about matching care needs to solutions, how the assessment process works, and how are we managing that at the minute. And then once we get through that process, if we meet eligibility criteria, there's then a bit about care and support services themselves and how we're actually delivering those and how we're achieving quality with those. So just to skip through the 3 sections, the first section on kind of the prevention agenda, there's a lot of narrative in here. I will share the slides afterwards. I'm not going to read the narrative out. I mean, the first whole bit, as Wendy touched on, is about communities first. It is about engagement with the voluntary sector. For me, this is the main game in town now for the public sector to survive going forward. We have moved towards a dependency model, in my view, and we need to move back away from a dependency model where we get communities to be empowered, we get individuals to be empowered, and a lot of the solutions that we need happen before you get anywhere near a statutory service, and we need to be thinking about how we're empowering that, how we're dealing with that. We're doing a lot of work with Jill's teams around developing the Northumberland Communities First model. In turn, that means a lot of work with the voluntary sector, and it means a lot of work with partners. Within this, the question is, are we doing this the right way from an adult social care perspective? Are there things we're missing? Is there other things that we should be doing? Again, I'm not going to go into the nuances of the individual things we're doing at this point. This is a start of a conversation, and with individual organisations, I would want to talk that through as to whether you think we're getting this right at this point. And that's the flavour that runs throughout these slides. The next big area around prevention is housing. We've been really frustrated with housing, I have to say, from our point of view. We had quite an advanced scheme of delivery around extra care and supported housing pre-COVID that fell flat on its face when COVID hit. Because developers got twitchy, construction companies started to lose labour, a lot of things slowed down. I know Wendy gets very frustrated with us about this one. It's a big thing that she wants to push forward. But we're kind of ready to launch again now, and we've got a lot of things in the pipeline now that we're hoping over the next 2 to 3 years really will come to fruition. We have potential extra care schemes in almost every major area of Northumberland, either in process or in the pipeline. I have put together a bit of a war chest of grant funding to be able to support that where we need to put council intervention in. But what I'm really interested in is I've seen in other parts of the country, and I've been involved in some of them, some of these schemes do fall flat on their face once you build them. We've had some, I'm not going to name in neighbouring authorities that haven't gone particularly well in terms of the development of housing schemes. So I'm particularly interested in information on where to get this right and where people think that we can. Because in reality, if you stick an extra care scheme in a rural area, we need people to move into that extra care scheme. They've got to be prepared to move out of their hamlet and go to it, or it's a waste of time doing it. And I'm interested in more quality information about, are we putting these in the right places, and are we going to achieve that when we get there? Because that's the big gamble for us when we're dumping 6, 7, 8 million pounds into a build. And there've been some real white elephants in one or two other areas that I don't want to repeat here in Northumberland. I want to invest our money wisely. We are having a good look at services that aim to reduce care and support needs. So we're looking at our STSS services, our occupational therapy, the sort of services that get in with people when they're leaving hospital or when they're in the early stages of dealing with issues, so that we can try and steer them out and away from the system again, re-empower them to be able to be independent in their own homes. A lot around mental health issues in that area, as well as to how we can get in early and signpost people into things that they're not going to come into the more acute side of mental health services and block up Chloe's areas in CNTW and inpatient treatment units. We do have some specific reviews there. We have a telecare service. We want to have a look at that and see whether we think we're maximising what we can get out of that. And there's a big government push generally around assistive technology, around prevention. I have to say I'm still a bit of a sceptic on that at the minute. I haven't seen much empirical evidence of that actually achieving a lot in many areas. There's a lot of sales pitches from IT companies. I'm looking for some hard evidence. If I can find some hard evidence that some of these will deliver for us in Northumberland, I'll rip an IT company's hand off to do it and we'll get it in. But at the minute, it's still a bit of a watch and brief on that. But we've clearly got to be looking at that as the way forward. I think robotics, I keep saying this for people who've heard me preach, and robotics will be the key step. And Japan are getting close with that. But whether we can afford it when it comes across, we'll have to wait and see. Moving on to the assessment process then and matching care needs to solutions. Everybody at the minute, when they have a need with a company, goes to the website first. And we have to accept that, younger people with aging family members are going to hit Northumberland County Council's website first, generally, when they want to interact with adult social care going forward. It's less common to pick the phone up and ring what is our one-call service and things like that. It will be less common. Our website's not brilliant still at the minute. It's not bad. We've improved it over the last 6 to 12 months, but it's not brilliant, and we need a big push on the information that we're getting out to people when they first hit the system, because that actually means they may be able to self-serve to some degree, and they might not suck up our resources as they're coming through. So we want information on people that are using our website and using other forms of communication with us. What is hardest to find when you approach us at the minute? Tell us about that so we can improve it. And we want to start to loop that feedback back through. And that would apply to partner organisations as well who are interacting with us. It's not just about clients and family members and carers. We want to coordinate care and support better. This is a repeating theme. We have restructured adult social care 2 years ago, and we're about to look at a restructure again to try and reduce handoffs for people when they come into the system. We've had some amazing examples of working with partners in the past, some of which are still in existence and some of which we're trying to rebuild at this point in time. And we want views on how we can make that even better. How can we streamline our services internally in adult social care and stream them with the other organisations that we're working with to make things as smooth as they can for people that are on that journey through the system. And there's a specific issue around 117 that I know, Chloe, you're picking up with Karen and that we need to get on top of as well for people who are coming out of the mental health system through the Section 117 aftercare route. Lot of narrative here. I'm going to summarise it in a couple of sentences, but broadly, this is once we start the conversation with somebody, the care does hamstring us a little bit. There's a lot of annoyances and technicalities about what we're supposed to talk to people about written down in legislation that we think might be hampering the conversation. So we want a dialogue about how that can be more open-ended. A social worker, when they're talking to somebody who's approached us, should be talking about what do you want to get out of the rest of your life here. You know, what would improve your living situation? You know, if you're nearing the end of life, what will maximise the positive aspects of the last few years of your life as you're going through it? Often the conversation has been about resources. You know, how many hours of care do you need? Do you need to go into a care home? Don't you need a care home? That needs to be the end of the conversation if we reach that point. We want a much fuller conversation and richer conversation about how can you get a better life with whatever disability, whatever frailty, whatever's brought you into our system at this point. And there's some technical bits down there. We're looking at generally improving the kind of, again, people being IT enabled, coming in through the web. Can you do some of that assessment online first? So we bypass part of the conversation and get quicker to the meat of it, which should be the high quality conversation about what you want out of life. There's a little bit here about when people can't make decisions for themselves. This is a high risk area for us. And unfortunately, often, we can not always agree with families about what's the best outcome for people. And there are sadly times when we think families may not always be acting in the best interest of individuals, and we've got to get this protection mechanism right. So there's a bit in there wanting to talk to people about, are we getting it right? We know there's examples of where we haven't got that right at points in time, and that does become high risk, and it will for NHS colleagues as well, I know, where we're having to step in and make decisions on people's behalf. Again, we want to open up that dialogue. The paper talks a little bit about our direction of travel there, but have we got this right? And are we doing the right things? And carers is the other big theme in this area. We had a peer review a few months ago, and the peer reviewer, when they ran through the evidence with us, said everything is screaming out here that you're doing a really good job with carers in Northumberland. When you look at the levels of satisfaction, they're beyond what is reported in most other parts of the country, but you can't prove it. When we actually go through your documentation, we have a look what's written down about carers assessment and things like that, you're really light in that area. And there's a lot of work we need to do, I think, just to be able to record and reassure ourselves that what we're doing with carers is right. And then there's a whole dialogue, which I know we're starting with Health Watch and partners as well, with carers themselves to say, and what more can we do? They become little hotspot issues in this area. We know respite care is a key issue for carers at the minute, and they don't feel there's robust enough access to respite care. But we want to understand in the wider scheme of things, are we getting this right? And then lastly, to skip through care and support services, direct payments, which is where we give people money in lieu of a service, the take-up of that is very light in the North East, and it's even lighter in Northumberland, and we want to understand why. And we want to try and create a model more where we empower people to take the money and potentially manage their own care rather than being dependent on us sorting those services for themselves. Some people have heard me say before, I worked in the Thames Valley area, and there was a much bigger take-up of direct payments down there. People felt much more empowered in that area, I think, and maybe that was to do with the way life works in that area, perhaps a more entrepreneurial environment. I don't know. I'd love to get, to be honest, Newcastle College to do a thesis on that to try and understand whether that's a North East dependency issue or whatever. But we want to push this. We want people to be empowered, and we want them to take control, and we need to understand how we can make that happen. The care workforce, as I mentioned at the start, has been one of the biggest issues we have, and we've done a shed load of work as a council and been supported by the Cabinet to deliver that. We've increased wage levels to above most of our regional neighbours and well above the national minimum wage across the country. We know overseas workers has been a big support to us resolving some of our workforce issues. But now there are sporadic incidences arising of exploitation of overseas workers and things like that. So we want to engage with everybody really, to including overseas workers, to understand what's working well and what's not working well, and how can we support that, because we need a robust and stable care market going forward. And as we have an ageing population and fewer people of working age, that's going to get harder and harder to achieve as everybody wants to pull from that pool of staff. Care in people's homes. As I say, off the back of sorting the care worker crisis out, and obviously home care being our preferred solution when we get to a model, we don't want people to go into care homes. That's not the preferred thing. We prefer people to stay at home. We want to just make sure we're getting that right here. In particular, we have gone down a route in Northumberland that not every authority's gone down, of letting almost everybody come onto our contract. So now anybody who wants to provide home care can come onto the Northumberland contract and do that, but we're starting to think that may be having some negative effects in terms of fragmenting the market and having too many providers in the game, which means that staff are jumping between providers, and we just want to learn, again, this is about sustainability and robustness, and we want some feedback on that to understand if that's working well or not working well, whether we actually need to reduce the number of home care providers, not increase them in Northumberland. And then I've mentioned extra care at the start, but again, so there's extra care in the sense of prevention and supported housing, but then there is about getting support into the care as well when we have that. So there's a little bit in here. We want to know if we've got that right and what can we do better in the future around accommodation with care. And then lastly, just some other bits, some other care and support service bits. I mentioned direct payments already. We do want to expand our shared lives service. We see that as a really good model. It's been primarily focused on people with learning disabilities, but it doesn't need to be. It could support people in any client group. For those who aren't aware, this is basically foster caring for adults, and is seen as a very robust model for people with high dependency and a good quality model. And then lastly, we do get people who approach us with unusual needs, and we don't think we're always, if you're out of the box a little bit, we don't always think we're good at dealing with that. So again, we'd be particularly interested in suggestions of where we've got gaps in provision for people that are present with unusual needs, and having some conversations about that. And that's the whistle-stop tour through the document. Guess my plea now is, it's not to go through the document in detail in this session, but the plea is, can you have a think about, for your respective organisations, how we can engage with you? For some organisations, you might want to talk to us about the whole document, and we want big, heavy sessions on that. For other organisations and bodies, there'll be parts of this that are of more interest than others. Healthwatch are being brilliant with us, Peter, at the minute, and Derry's helping us to start that conversation with people with lived experience, and we're looking at compartmentalising bits of this and then bringing it together into our People's Advisory Group for a bigger chat, and we'll be looking at other forums. We'll be using the Carers Forum and other things. Partners are massive in this. This is not an adult social care strategy on its own. It's a strategy for all of us, because if we get this right, we will relieve pressure on the NHS, we'll relieve pressure on CNTW, we'll relieve pressure on the police, on everybody, so we really, really want to get this right, and I appreciate that engagement going forward. I'll stop there, Chair. Thank you for that.
Thank you very much.
Yeah.
Yes, please, Graham. Yeah.
Thanks, Chair. Thanks, Neil. There's so much in that report that I was thinking, well, we could spend a lot of time and make small incremental suggestions for absolutely everything in the report and feel like we've done a really good job. And then I was thinking, how else might we apply it and put in that inequalities plan and community strength side of it? And therefore, the focus may need to say, so in our places where people get less opportunity and do less well, where can we focus to make a difference there? So if you were coming around to employment or housing, for example, like you said, what works in one place wouldn't work in another. And our statutory organisations probably aren't best placed to understand that to the same degree as others. So it might be that there are different groups that we want to really focus and say, but if we wanted to make a difference in terms of the healthy life expectancy in certain communities, it looks different from different viewpoints. Does that?
No, I think you're absolutely spot on. I mean, it's one of the beauties and the exciting things about working in Northumberland is, it's probably much easier in North Tyneside, isn't it, when you're 4 miles square or whatever, that we will have very different needs in different areas, and we will be looking to have conversations with different groups in different areas off the back of that. So primary care is a really interesting one. I'm having a conversation with Saul next week about how we can take this into the primary care arena. One of the things I was going to talk about is, do we need to compartmentalise that? A little bit like what we're talking about with Healthwatch, about compartmentalising with different people that interact with us in a different way to get those conversations. I think we may need to nuance it a bit. I mean, we did start on Tuesday this week, and we've done it very quietly. We're not making a big song and dance about it. We've started a prevention, we're calling it Prevention Hub at this stage, for want of a better phrase. We're still inviting the title, where we're slightly changing the way we work in Cramlington. And part of that aim will be to get anybody that approaches adult social care coming through a single point where we better join up our professionals in adult social care to get a more holistic approach to what's going on. But we want to information gather through that. The voluntary sector are involved in that as well in that area, which means we start to get quality information that kind of feeds into this, but more by a granular basis of actually working with people to start developing those services. And we're going to try and replicate those hubs in different parts of the county as well. I mean, we're piloting it in the minute to make sure it works, but we're looking at potentially the north for a hub, and we're looking at the west for a hub as well. And we'll gradually, I think we'll get a snowball effect of growing information and intel that will allow us to stimulate this sort of development moving forward.
Yes, please. Yeah.
Thanks, Chair. Thanks, Neil. It was a really compelling narrative that you've just shared. And I think the beauty of it coming here is how much it fits with when we've had the DPH report coming, talking about ageing well and the rising tide issue, because this is a tsunami for us if we don't work on it. So it's great to see that prevention as a core component. And Wendy, the way you described that movement from the learning and what's worked really well with Northumberland communities together into that next phase of communities first. I think language is a really interesting one, because Neil, you'll refer to it rightly so as a prevention model, but that is for us communities first approach, isn't it? By looking at the data in a different way, we can predict demand earlier, and rather than it potentially being a dependency model, it's what's already in the community with the voluntary sector. Enabling independence ultimately, isn't it, is a key goal for us, which then also links very nicely with our Refresh Joint Health and Wellbeing strategy, where we've got empowering communities as a overarching theme. But then the other bit that I just wanted to touch on was when you talk about housing, and we've just obviously launched the relationship with the Institute of Health Equity. We're going to be doing a deep dive around housing, and they know for us it's about rurality, but it's also about our ageing population when they're looking at how we can do more further faster around housing and good, safe, warm homes for us. So it just all feels like it's knitting together, and the more we can support and work alongside you, because you're right, it isn't an adult social care strategy. This is for all of us to own and work with you on. So
Thank you. Graham, yes.
No, I was pointing you out to say.
No, he's reminding me that please, there is...
Keeping them right.
Thanks.
I really welcome this. I think it's absolutely in the spirit of everything we're doing at the moment. Everything Jill's picked up there about a lens of inequalities that we must look through. I'll regularly sit at this board and look around and say, what are you doing? What's your contribution? My commitment is to be fully committed to the conversation. My request is that if my service isn't around the conversations that you're thinking, why are they not here? Why are they not in this conversation? My commitment is to make this fire and rescue service as part of the County Council, as the most integrated fire and rescue service in the UK. That means that I take the commitment to upskill my staff, who have a fairly unique strategic footprint, the length and breadth of the 5,000 square kilometres of Northumberland, and we are ready and willing and able to mobilise to be able to support things at that local level, so that community resilience piece as well. At the moment, over in Cramlington, we're starting a pilot around how do we look at not just a falls prevention, but a falls response. If we can prevent one fall, and the dominoes, the social care dominoes that can fall from that, from right back to when the ambulance, if we can stop the ambulance mobilising, actually who else gets the benefit of that ambulance? If we can stop the fall happening, the hip fracture doesn't happen, the admission to A&E doesn't happen, the housing adaptations don't happen at the point of exit from hospital. So my commitment, as I said, is to be fully organisationally part of that conversation. But the request is that if we're not at the table, please ask.
Yes. Thank you, Graham. I think we are really happy to have a very enthusiastic person from the fire playing such a good role in this board. Yeah, thank you very much. Are there any? Yes, please.
Thanks, Neil. I think this fits, well, it's hand in hand with CNTW Mental Health Community Transformation and the review of our whole clinical model. So I would welcome a more in-depth conversation outside of here and how we link in to those key work streams that we've got going already, because all of this really fits with what we're trying to achieve as an organisation with multiple system partners. So thank you for bringing it today, and I'll drop you an email around that.
openly said that we are not so good at meeting unusual needs. Can you give us a flavor of what those needs are generally? I mean, it's not being judgmental. I'm just being more, inquisitive as what those needs we face.
Yeah, one of the most common areas that springs to mind in terms of that is often complex mental health needs. So yeah, I mean, most things fit into a box for us around frailty, disability, and things like that, and you tend to be on a spectrum. I'm not. The conversation I want is that right, or is it not right, and should we actually have more varied things? But where we often struggle, I think, is around complex autism, complex mental health, and trying to find the right solution for people there that don't quite fit into either, as you say, one of Chloe's services where you're going the other side of a door necessarily at that point because you need to be safe. But then when you're out in the community, is how do we wrap something around that in the community?
Right. Thank you. So, are there organized conversations across the councils? Like, do you often have some kind of, coming from an academic background, we often have conferences where we put our heads together just to exchange the views. So, are there similar things running in that case? How we are doing in the participation of such organized conferences or chat or discussions and everything?
Yeah, I mean, regionally, the link up between councils for adult social care is excellent. So we have what is called ADAS, the Association of Directors of Social Services North East.
Right.
And there is a meeting at my level of DASs that happens twice a month. But then there's a regular meeting of professionals in other spectrums within that. So you'll have a performance meeting, a heads of service meeting, and there'll be specialist forums put up for certain issues that we want to look at. So workforce, as an example, there's an ADAS workforce forum, and those discussions happen at regional level. And then at national level, yes, there's conferences several times a year where there's an exchange of ideas in terms of speakers and things like that. So running very similarly.
Good. Yeah, thank you, Wendy.
I also sit on the ADAS panel as a county councillor with other county councillors, and they go down as far as Middlesbrough.
Yeah.
So we do get conversations about what's happening.
Across the UK.
Across
I thought so, but nevertheless, I thought I would ask, and then so we can we can have a good view of what exactly is happening. Thank you very much. Okay, so let's. If there are no other questions, suggestions, we will move on to the next item. Oh yes, the next item, item number 6, is the long-awaited Joint Health and Wellbeing Strategy refresh. So we have updated that strategy, as you may know. We had quite a few sessions, and this is going to be formally presented and accepted here. And I think I am supposed to give an introduction, so I will do so. My introduction has got 3 small parts. Rationale. Why did we do it? And then what we did. And of course, third part is acknowledgement, because it's not a single person's effort, it's a collective effort. Yeah, okay. So what's the rationale? Since 2018, version of strategy, I mean, in the sense that after COVID happened, it has shone more light on the inequalities that exist within our communities. So in response to that, there are several organizations that have polished their strategy. That includes NHS long-term plan and development of integrated ICS and IPS, ICP and ICS, and the Northumberland Inequalities Plan, Core 20+5 approach to reducing healthcare inequalities, and so on. And of course, it includes a new Northumberland County Council corporate plan also, where we focus, emphasize on inequalities, tackling inequalities. So that's the rationale. It has therefore become important that we refresh the actions and indicators of progress in our joint health and well-being strategy to align wherever possible with these plans and strategies, each of which has tackling inequalities at heart. So, by demonstrating the commitment to tackling inequalities, an inequalities plan was developed by senior leaders from Northumberland County Council and the NHS, voluntary private sectors, including businesses, who work together to ensure the whole system works collectively to tackle inequalities and start to reduce the gap in healthy life expectancy. The final 5 years of this 10-year strategy will work towards the generational change that we need to see happening. As a health and well-being partnership, we have a strong commitment to continue building on this successful relationship to deliver this ambitious strategy. So this is from the written paper. Speaking from my heart, okay, I really wanted this refresh. I've been completely supportive of every effort that went into. And, recently I was reading the biography of Lee Kuan Yew. He's the first Prime Minister of Singapore. Great leader who changed a backwater city into a international city. In this biography, he notes he was here in London 1950 to graduate as a barrister. He was a lawyer. And he walks across Trafalgar Square. There he sees a newspaper stall, lots of newspapers, and a box. People pick up the newspaper and put the change in the box. He writes, "This is a hallmark of a civilized society." He looks at that, people are trusted, people respect each other, and then they pick up what they want and put the money. It's unmanned. See, we may not be so civilized in certain parts of London today, but I believe, Northumberland in particular, still we have lots of things to be proud of. This strategy we have here is a hallmark which shows that we are still a civilized society in caring for others. When we see inequalities, okay, and we see it as a preventable disease, okay, curable evil. So we put our resources together and then come up with a refreshed strategy to tackle it head on. Again, there are lots of organizations involved. It's not just council. We don't lead it, but we co-lead it in collaboration with so many organizations like fire, police, who joined recently. There are several private and private as well as government organizations. Lots of work has gone to. And let me also thank you for the whole of board for coming up with this strategy. And of course, Director O'Neill's team in putting in lots of effort into coming into this. So I'm happy to present this. And following my long talk, I would ask Veronica Jones to give a brief overview, and then Jill will introduce that one.
Thank you, Paul. I'm not sure what I can say after that, actually.
Sorry about that if I had talked long. That's a lecturer's
However,
disease.
I've got my notes, so I'll say them anyway. I mean, to be honest, I'm not going to say a great deal, because each section of this health and wellbeing strategy we've brought to the Health and Wellbeing Board, and we've looked at it in detail. So this is a pulling together of all the things that you've already had in front of you. So this strategy is actually from 2018 to 2028. 2018 was our move from being more of an aspiration, that we had a Health and Wellbeing Board strategy that was, this is what we'd like to do. Right? In 2018, it was the first one where we actually set out aims. We did a 10-year plan, and we had but it was setting out the aims of the strategy, and it was more of a mapping where we are and where we'd like to go. These next 5 years have got far more detail. This is a refresh of where we were, and it's moving it forward. So this time, we've got all the actions that go with it. So, you know, within the building blocks of a good life, we've got housing, transport, healthy neighbourhoods, all the things that really matter to people if they're going to have that good life, and we're going to have a strategy that works for everybody. So it's basically what you've seen already, following on from the previous 5 years. We've still got the themes. We've got starting and growing up well, we've got the whole system approach, and we've got the building blocks for a good life. What's changed slightly is the fourth theme, which was about empowering communities, working with the voluntary sector, and the work going forward means really we need to do a stronger role there, and the voluntary sector role will probably sit across the top of all the others, working and providing assurance that we're going in the right direction. I think that's it, really. I'm very happy to speak to this. I think it's one of the, I keep saying one of the best things we've done, but, you know, we have so many things that the best thing we've done, but I really like this. Thank you.
Thank you, Veronica. So I'll hand over to you, Jill.
How often does a strategy get 3 introductions? So I'll be brief. Obviously, when we stood down the April board, we sent this out virtually because it was due to come to the April one. We wanted to send it out virtually because many of you were at the Inequalities event on the 17th of April, where it was on the tables. So whilst it's an electronic copy for you all to use on a regular basis, we do have a few hard copies if anyone hasn't got one and wants to have that. There's not much more I can say beyond what Chair and Veronica have said beyond. This is, in effect, the first 5 years of our 20-year generational change. It is more clear, it is more concrete, and it absolutely has been co-created for us to have those steps towards tackling inequalities that we can measure, because that's been something that when we went through the review, people want to know what difference are we making when these ambitions are such long-term. So it's there for us to use and to build into your own organisational plans. I think that's the key point that I wanted to make. And also, whilst we're thanking everyone in the teams and organisations, unsung heroes often get missed. So Claire Malone, who is sitting in the back, not a part of the group, is our public health communications and marketing lead, who has made this such an easily accessible document. So shout out for Claire, because she never gets one. So thank you all.
Thank you very much. Are there any suggestions or anything to say? Right, okay, thank you very much. So that will allow us to move on to the item number 7, which is to be presented by Graham Reiter. Yeah, and yeah, please. This is about Children and Adult Safeguarding Partnership Annual Report. We're going to say how the integration worked, challenges faced, issues addressed.
Okay, thank you, and good morning again, colleagues. I think it's probably quite timely to have this following the overall strategy, because whatever we do across the partnership, we've got to be assured that we are safeguarding and protecting all of our residents. And what we want to do today, this is based on the annual report that was reported from September last year, but really is to talk you through where we've got to in terms of our safeguarding arrangements here in Northumberland, because it is different to most places nationally. I want to talk you through, and so you are clear on and can ask questions and challenges on how and why we've got to where we've got in terms of our oversight and scrutiny of safeguarding practice in Northumberland. So, as I say, what you've had in your papers is the first annual report of the Safeguarding Partnership, and that report does satisfy the statutory requirements for both children and adult safeguarding. And what we've done, the innovative thing we've done, is integrated our adults and children's safeguarding partnerships. Now, that is probably a different direction of travel from the vast majority of local authorities nationally, which have been actually where they have been joint, or they're generally moving in opposite directions in terms of going for children's and adults separately, because there's different legislative requirements and different things hitting those respective sectors and how they need to develop. But But we thought there was added value and benefit for us to integrate those two partnerships. Now, prior to what I'm going to talk through here, the Adult Safeguarding Partnership was linked with North Tyneside, and Northumberland, the Children's Partnership was there. And I'll give an overview. I've been involved in Children's Safeguarding Partnership work for very many years. And I would be critical of a lot of it as talking shops with no impact, and a lot of people sitting around a big table, the effectiveness of that safeguarding work being about the quality and effectiveness of about 3 or 4 individuals rather than a collective, shared, active responsibility. And I think there is a background to that. And again, to be clear, safeguarding partnerships aren't about operational delivery. They don't manage operational practice. They oversee, scrutinise, challenge, develop. And I'll come to that, about what and how safeguarding practice is undertaken. So I will talk a bit about the structure, because previously, generally, safeguarding partnerships were, as I say, a lot of people from a lot of agencies sitting around a very big table with an independent chair to provide that independence. But actually, I think the engagement was quite limited. So what we've done over the year from 22 to 23 is develop a structure and process that I think has ended up being meeting the statutory requirements of both adults and children's services. And if you look across the bottom row, we've combined subgroups which do a lot of the detailed work where we can integrate them, and it's right to integrate them between adults and children. We've done that, but equally where it's necessary and required, then we've kept separate children's or adult services depending on what it is there. So, for example, we've kept a separate group for disabled children. We have got a Safer in Education, it's now called Safer in Education group. And again, just talking from a children's perspective, there's a lot of talk nationally about making education a 4th statutory partner. In children's services, it's local authority, it's the ICB and it's police, who are the 3 statutory partners. Now, how you actually represent education is a really big issue. I mean, I think we do it appropriately through the DCS, Audrey Kingham, who offers a range of things. But actually, in practice, and we have talked to the DFE about this, we've got a Safer in Education subgroup which actually effectively engages with a range of schools and education establishments, designated safeguarding leads in those schools, to actually, in practical terms, make sure education is shared, discussed and done on a county-wide basis. And I think that is a much more effective way of making education across the piece a key element of being a statutory partner, as opposed to have somebody nominal sitting on some board at the top of the structure. So we've shared that as good practice. But again, if we go across the board as well, we also need separate groups, I think, for the learning reviews, just because of some of the requirements around those. But again, the details there, and happy to take any questions. But where we can, we've integrated. The chairs of all of those groups will be from the range of partner agencies. There'll be some from local authorities, some from the trust, some from ICB, some from the police. So those partnership subgroups are all chaired across the partnership. Then they're pulled together, if we're going up into the subgroups, the children's business group and an adult business group. They are chaired by the independent scrutineer, and I'll come on to, again, the role of the independent scrutineer, which I think, again, we've got an innovative approach to here. But that gives that independence at that level, but also allows sufficient focus on the respective adults and children's safeguarding issues, requirements, and practice developments. But what it then does with the executive group, between those groups and coming to the executive group, the shared learning, I think we can maximise here. So going back to our original reason for having this structure and this integrated partnership is thinking that people aren't in silos. So we'll take one of our priorities, domestic abuse, will affect everybody in the family. It's what are the opportunities for thinking and learning family. So domestic abuse will be one example I give. Obvious impact on children when there is domestic abuse in the household. One of the other things, when we've looked at data, again linking across to the other partnership work around domestic abuse, increased understanding around domestic abuse with older people. In terms of that. So what is the shared learning? How can we develop and do that in a coordinated way when there is a lot of crossover around that? So again, we've got an executive group which I've chaired for the last 2 years, but we'll be handing that on as part of a plan. So we will have a partnership chair for that. That fits with working together requirements that come in around children's. So either the police or the health negotiations to be had, but we'll be chairing that for the next year. So we've got a rolling partnership chair. So just taking all of that, What we've got, I think, is an effective structure that's focused on the key areas where we can scrutinise and oversee the practice, but share learning across between adults and children and across the partnership agencies for that. And again, at the top of you see the range of partnership, other activities that there are, which we do have effective links for, but they do continue to evolve. I've got to say, we've taken this isn't a set structure. We will continue to evolve this as we need to do. So that I've spent a bit of time on the structure. I think that's important to understand how that has operated. And again, I've just probably already touched on these things, but these are the kind of elements of what safeguarding partnerships should do. I mean, it's modelling strategic leadership, ensuring safeguarding is everybody's business, that the arrangements are effective. It is about learning, so we'll look at a range of ways. And what we do is maximise each agency's quality assurance work, as well as doing stuff as a partnership. So we bring everything together to understand how effective the work is and where there are areas that we need to develop on, and that then leads into the learning. I'm going to talk a bit about the scrutiny. So what we've done, as I say, previously you will have had Paula Mead, was the independent chair of both the Adults and Children's Boards, coming to this meeting talking about that as the independent chair. What we've done is, and again this is driven by children's legislation, an independent scrutineer. So we've employed somebody independently who's got significant experience in partnership safeguarding work to provide independent scrutiny. While they do chair the business boards, that person will also do a range of other activities, observing groups, getting the voice of children and young people, looking at our data, providing challenge to us in a whole range of ways that will enhance and give us constructive challenge to what we're doing. We do a range of other activities alongside that scrutineer to know what we're doing, like this self-assessment, like a range of quality assurance work, like analysis of performance data across the partnerships. But I think the key for us is also how we've developed and used an independent scrutineer in terms of that. And the impact, and again, we always should ask this question for all of our partnerships, the so what question in terms of that. And I hope there's demonstrated within the report, and again, I'm happy to take questions about how do we know that we're being effective. And I think we have got effective quality assurance oversight, which we continue to evolve and develop. We are putting learning into practice in terms of that, and we can see some of the practice developments across that. But again, that is a continuous challenge for us, that we're not just sitting, being a talking shop, having no impact on the bottom line. That was one of the key elements of that. I'm probably going to ask Heather to say something, because Heather's been part of a number of the groups here in terms of how we've experienced the change, if that's all right.
Yeah, so I actually have the luxury of sitting on most of the groups within the partnership, and I have previously been involved when we were joint with North Tyneside as well. The benefits we see in Northumberland is the whole family approach. We have already been modelling this within our front door service for a number of years, and what we have found is that works. We've had local authorities travel up from all over the country to come and look at our front door model and how we take that whole family approach. So setting our partnership up like this has had huge benefits. And a key example of that is we know in Northumberland neglect and self-neglect is increasing. It's increased post-COVID. And particularly within our ageing population as well, we are beginning to see a theme of people who necessarily didn't come to the attention of adult social care, but since COVID, they are now coming with quite chronic self-neglect. As part of the partnership, we now have a task and finish group for neglect and self-neglect. It is one of our new priorities, and I chair the task and finish group for that. But what it is allowing us to do is really look at, okay, childhood neglect, the impact of parental abuse, and how does that bring us into adulthood and the impact on self-neglect. And we're very much looking at preventative services in terms of how do we stop that moving forward, because the increase is so significant. And we've had a number of safeguarding adult reviews, cases brought to the SOG, where we're actually having a thematic review as well to look at what can we do differently in Northumberland. We've attended lots of kind of forums that tell us we shouldn't be starting from scratch with neglect and self-neglect. We already know a lot about it. It's about looking at a different way with a new approach. And what the partnership is doing is it's allowing us to do that. We're getting data from our data groups. Then there is a slight change in the model. We have now merged adults and children's performance groups because it's really essential we understand what's happening to a person from when they're born right up until they sadly pass away, and we need to see kind of themes going alongside that. The communication between the partnership is excellent. We've got some real experienced staff attending the groups, and that's bringing a wealth of knowledge from every aspect of the partnership, whether it's health, the fire service. You know, the fire service, when it comes to our neglect and self-neglect kind of task and finish group, bring a lot to that as well and really kind of support us within that. So we are seeing the kind of benefits of that, and then operationally we can take that. And I think the biggest thing about the new model is we're able to evidence, okay, are we doing better? We've got our practice learning group that kind of looks at the evidence of, okay, what have we learned, what have we changed, but how do we know it's actually impacted? And that's huge for Northumberland because that's what we want to be able to do. And look at alternative ways of working as well. What can we do differently? How can we make things better? So yeah, it's working really well within the first 12 months.
No, thanks, Ed. And again, I mean, there's a link to independent scrutineer's report, but again, the independent scrutineer would say that that would be the feedback from all the participants in terms of feeling much more active, proactive and effective engagement. I'll probably rush through some of the other stuff because, again, that's about some of the scrutiny activity I've already talked about, but as I say, particularly focusing on the role of the independent scrutineer. And again, just in terms of external evaluation, we had the Department for Education come and see us about a year ago to look at this model as a model of good practice, particularly around the scrutiny arrangements there. And we certainly have been contacted by a number of colleagues nationally to have a look at the practice and the processes that we've developed here in terms of that. And again, Heather's articulated, I think, very effectively, whilst we have priorities across the children and adults and cross-cutting, actually a number of those are cross-cutting anyway in how we approach and learn from them. The example of neglect being one. Mental health, again, Neil's obviously referred to that in the earlier presentation, around complex mental health with young people, but equally with adults. So there's the learning and opportunities for us to share across where we need to and where that's right. And similarly, risk outside the home, which I'll come on to in a minute. I'll just move us on to there. So we've got some learning from reviews, and that is only one element of the quality assurance in terms of that. But I will just talk again briefly about, I think, some innovative practice here. So we have a range of reviews, and I'll talk some of the themes here. But in terms of reviews, and again, there's links across to the domestic homicide reviews and DHRs, where there's a lot of, I think, learning. Again, in children's services, over many years, we've had serious case reviews where an author takes ages to write a review, there's an action plan, and years later, you're kind of just struggling to justify the impact around that. And one of the things that we've developed, when there is a serious incident in children's services, which, goodness knows my area of knowledge, where there's a serious incident which meets the criteria for notification to Ofsted, i.e. serious harm or death of a child, and there's multi-agency involvement with that, we now hold what is called a rapid review, which pulls together across the partnership all the learning very quickly and is then analysed to see if there is any merit in further learning, because actually most of the time most of it we'll know already. There won't be anything new to learn by investing in somebody to write a very lengthy report that will be published years later. We already know most of the stuff. So what we have tried and started evolving with the links with the Safer Northumberland partnership, that rapid review process to try and focus in. If we do need something more in depth, then fine, that's good, but it's very clear on what is being focused, and it isn't a very generalised, let's just have a look at this in particular. We can focus what we're doing. We're starting looking at that around with adult services as well, and just I think two we've just initiated around adult learning. But the one I will just bring you to, we have just published a learning review in children's services where we've taken a very different and I think innovative approach where we've engaged the family and the young person involved, but also all the partner agencies. And the report itself has been written in the voice of the child. So just in terms of trying to make an impact, as opposed to kind of dry professional language, and there is a role for that, I've got to say, just to see if and how that worked. Now, the national panel were very interested in this approach, and we met with them actually last week to review it, and they had some constructive challenge around it as well in terms of what might have been clearer. But what they were positive about was that the approach did focus on the impact on that child or that young person. But what it also did, the process was taken on the basis of appreciative inquiry, a positive learning approach, as opposed to a finger-pointing blame approach, which I think historically people who have been subject to things like serious case reviews would have felt. And I've certainly been on the receiving end of those, and you don't particularly want to open up, share stuff about yourself or your practice or your organisation when it's likely to be published and you're likely to get some brickbats coming with it. So not dismissing the negative or the learning opportunities, but taking a positive way. And the feedback from all the organisations and the participants in that was really positive. And what we also developed was the learning as it went along, as opposed to just having to do a set piece of work, then do an action plan. And there is an action plan coming out of it. So again, the feedback nationally, having scrutinised that for the national panel to which all those reviews have to go, was positive, but with some constructive challenge about things we could do better. But I think it just demonstrates that we want to try and do things in a more resident-focused way, innovative way that actually makes a difference, is what we're trying to do. There is a range of other things that have come from the reviews there in terms of the learning, but I think Heather's already given good examples of how we can do those. So I think in terms of that, again, that's looking forward from last September, again, some of the shared priorities that we've talked about, again, with evidence there. So it really is for all colleagues here to be aware of where we've got in terms of our structure, practice and processes around safeguarding. It is everybody's business. And I think just happy to take any discussion points or challenges around where we've got to in terms of that across the partnership.
Yeah, great. Thank you very much for the report. Yes. Are there any questions, suggestions to the Graham and Heather? Yes, please.
Not a question, just a comment to absolutely agree in relation to the partnerships working across as well as up and down. So a number of us sit on the Safer Northumberland partnership and we've got excellent relationships. I've met with the new independent scrutineer as well. We're going to continue to meet on a quarterly basis, but I know obviously Graham you sit alongside that Safer Northumberland partnership too. So there is absolute join up and connectivity, hopefully without duplication too much as well.
Thank you. Okay. You want to say something? Yeah, please.
It's just really a curiosity about when we have an independent scrutineer, how do we know that they're doing a good job if they are top of our tree?
Good question. I think what they have to do is produce the reports, and so there's regular reports from the independent scrutineer goes in, but equally I think that the discussions that we have would be able to pick up if we were unhappy with the independent scrutineer. I do think the constructive partnership work in Northumberland really is a positive where we can have the difficult conversations if we need to around that. So I would be very confident that if any of our partner agencies were unhappy with the performance of the independent scrutineer, that message would be shared and we would deal with it appropriately.
Thank you. If there are no other questions, thank you very much, Graham and Heather, for a good, lovely presentation. Now we move on to item number 8, forward plan. Just please make a note of the plan for future. I think in July we have annual report of principal social worker on safe havens, and then it goes on. So if you have any remarks, suggestions, please tell us or email us. Thank you.
Can I come in on that, please?
Yes, please.
So we're skipping to July for the formal meeting here, but in June we have our development session.
I was going to say that.
Institute.
Date of next meeting, yes.
Okay.
Item number 10, yeah.
On you go then.
Thank you. And I think item number 9, Jill, you have some announcement or reminder on fluoridation?
Yes, please. But actually, if I may, I've just noted for clarification, back to the Joint Health and Wellbeing Strategy, the wrong link has been shared in electronic copies. So we've had a version control issue. The difference in the paper copy is that there's actually comparator data to the North East in England. So if we can just make sure the correct link goes out for all partners to use, please. So just to acknowledge, if you haven't got a hard copy, you've got the wrong link currently in the paper packs. So yeah, if I may, because again, with not having the April meeting, I've written out to, I think, hopefully all of you around the community water fluoridation consultation that is out currently. I just wanted to take a moment, if I may, Chair, just to highlight that we've discussed at length oral health in this board, and we know we have an oral health strategy of which a component part is the recommendation to progress towards community water fluoridation, which for us in Northumberland is an expansion of an existing scheme. It isn't about a new scheme coming into Northumberland. Indeed, we've had community water fluoridation since 1968 in many parts of Northumberland, so this is about making sure as much as possible the rest of the population does so. The legislation changed, so we are actually consultees. We are not the ones doing the consultation. And it is the Department of Health and Social Care who are leading this through the Secretary of State. And we are, as a North East region, the first in England to go through this formal public consultation because of all of the work we did whilst it was in our jurisdiction within the local authorities in 2017, 18 and 19. We were, if you recall, when Liz Morgan was DPH and I was over in Durham, on the cusp of going to public consultation, having had approval from the Secretary of State that it was deemed operable and efficient. So my plea to you all is when the email came out, the evidence briefing was there. We have, as an association of directors of public health, a position statement endorsing this, and also the link is there as well. So if you haven't already, if you have, many thanks. If you haven't already, please do log on. It'll literally take you 5 minutes. It's a very short questionnaire. What we are seeking is your professional titles in relation to the positive, hopefully, endorsement of this. I appreciate people may have personal views, but from a professional perspective, I am hoping and encouraging you all to complete this survey. Thank you.
Thank you very much. So that is the final item, date of next meeting. That's what I thank you, Graham, for taking initiative on that one. There is no meeting here on June. The next meeting will be on Thursday, 11th July, 2024, usual time. And next meeting is not cancelled, but it is being replaced by a closed development session. First thing we are going to have, and that will be Thursday, 13th of June. I do not know the rumors tell me that it's going to be in Cramlington Hub, but yeah, Graham will be announcing it. It may have changed.
Hot off the press.
All the details will come. Yes.
It's going to be at River Green, which is the ICB offices, which are near St Mary's Inn. So we would welcome you there. It feels like, we've seen this today, and now we're doing some other stuff with the Institute of Health Equity, and it just grows gradually. What we would like that session to be is very much the people in the room who have ownership of this and the inequalities plan, but it needs to be a wider audience as well. I think Jill would like us to think as organisations as to who else we would like to invite to that. I'm not sure how much room we have for everybody, so there's a little bit of work to be done. But it needs to be, and I'm thinking primary care need to have a slightly different voice there. The population health management leads may need to come to that. But there'll be other people, certainly housing, the workforce side of things as well. So we just need to have a think, and it will be more than just us in the room. And hopefully we can then do some of the doing with the data and the report that we're going to be given. But we're not sure exactly the nature of that yet, Jill.
No, so Dr. Jessica Allen will be leading the session from the Institute of Health Equity with her senior research team. So we've got a planning meeting with them, but as you recall, we've agreed on a quarterly basis that the Health and Wellbeing Board becomes the advisory group, in effect, of the Institute of Health Equity contract. So when we do get the diagnostic reports back, that policy of no surprises, because we have informed, we have shaped, we've shared our data, we've shared our policies, we've shared our ambitions, so that when we get that feedback, hopefully it is aligned with with what we want to see, but that further push for us to take things further and faster. And as you know, the focus is on housing and good fair employment in year one of this contract. So we will be certainly inviting housing and employment colleagues. But you're right, Graham, this is still a very senior advisory group. It's not a broader workshop for all of our staff teams. So if you are that right representative, brilliant. But if you do think you may need one other person or something like that, we just need to manage numbers so it's a strategic conversation that takes us forward still.
Yes. Thank you very much. Are there any questions on what we are planning to do? Right. Okay, thank you. So I think that comes to, brings this meeting to a conclusion. Thank you very much for coming. And we seem to have done in 75 minutes.